That brings me down to the last talk of the day. So now should have been the earlier slides, but now let's keep it to the last. So what are the jargons in the OCT, and how do we use OCT in research? So the what is OCT has already been covered. So what is NFAS? NFAS is nothing but, we have been talking about NFAS. NFAS is nothing but the 2D representation of the 3D volumetric data that has been provided by the OCT. And every NFAS is taken at a particular segment or a slab, which is known as segmentation slab. Then there are flow signals. Flow signals represents that the vascularity of the retina or the choroid, and these are the flow signals which are overlaid on the structural OCT. So, like any other investigative modality, OCT angio has quantifiable parameters, one of which is perfusion density, that is total vascular area. So how is it calculated? So any image of OCT angio undergoes processing in the machine or can be processed in other softwares. The processing happens that these images are converted to binarized images. What does binarized mean? Binarized means black and white. So in the black and white images, the white represents the vessels, and the white pixels can be calculated from that area, and that represents the total vascular area. Now, these binarized images are further skeletonized. What does skeletonized means? That this is the skeleton of those vessels. So in this, all the vessels have almost the same area, the bigger or the small vessels. So this is the vessel density. Then there is something known as blood vessel tortuosity. So it is the ratio between the geostatic distance and Euclidean distance. So what does that mean? That means that if we measure a vessel between the two endpoints, the shortest distance is the geostatic distance, and if you trace this vessel over the contour of it is the Euclidean distance. So the ratio between the two is going to tell us how tortuous the vessel is on OCT angio. So difference between the ratio between the binarized image and the skeletonized image can help us to know the vessel diameter. And then there's another important index which is known as vessel perimetry index. This is the amount of pixels around the vessels compared to the total vascular area. And now we have quantifiable variables for fovea. One of them is FAZ, foveal avascular zone, for FD300. FD300 is vessel density around the 300 microns of the foveal avascular zone. Then there is extrafoveal avascular area, which is the avascular area or outside 1 millimeter diameter center of the fovea. So you draw a circle on the center of the fovea of 1 mm, and any avascular area outside that is extrafoveal avascular area. Then there are flow areas. Flow area you can manually draw a circle, or the machine will draw a circle, and at the same time you can draw a particular area and you see how many vessels are there. The vessel density is the flow area. So unlike OCT, OCT is also not devoid for errors. So they are confounding factors that affect the OCT calculation. The quantitative analysis is also confounded by these errors. So because there's a lack of normative data, there's individual variations, age variations. Axial length can also affect the lateral magnification of the OCTA. So what it means is shorter axial length, the OCT scans area is smaller, while in myopia it is larger. So smaller area would mean that FAZ occupies a larger portion of the scan area, resulting in erroneously lower vessel density. So then how do we deal with it? We deal with it with some parameters which are not affected by confounding, one of which is acircularity index. So acircularity index is the ratio of the perimetry of the foveal avascular zone to the perimeter of the circle of the same amount of the area. And this is one variable which is not affected by the axial length or the magnification of the OCTA, or magnification happening by the OCTA. A particularly circular FAZ has an acircularity index of 1. Deviation from the circular shape of the FAZ will lead to increase in this matrix. Then there is radial peripapillary capillary vessel density. It is nothing but a vessel density around the disc, and usually calculated in between the two circles, which can vary in diameter depending on the type of the machines. So why do we need the assessment? Rakiosis and et al. Has suggested that FD300 is a sensitive biomarker to differentiate or to recognize the patients who is going to have a diabetic retinopathy. while extrafoveal avascular area in the superficial capillary plexus can discriminate between a non-diabetic retinopathy from NPDR. Vessel density in the DCP can help us to distinguish between the NPDR and those from PDR. While as the disease progresses, the peripapillary RPC perfusion decreases with time. So then there are quantitative parameters. How do the quantitative parameters that can be used in sickle cell retinopathy? One of which is acircularity index. So acircularity index and avascular density, that is extrafoveal avascular area in the temporal region of superficial capillary plexus. Apart from that, we know that the vessels are dilated in sickle cell. So dilated vessels or increased diameter in the sickle cell disease can be one parameter. Apart from that, there's increased tortuosity, which is BVT, blood vessel tortuosity, which is increased in patients with sickle cell disease. So OCT angio can also help us to assess the progression of the glaucoma. It can act as a pre-perimetric test, but to understand one thing which is important is that the peripapillary microvascular reduction is consequential to RNFL thinning, and it's not the other way. So OCT angio can also be used to look at diseases like Alzheimer's, mild cognitive impairment, and multiple sclerosis by measuring the RPC vessel density. So there was a lack of standardization. So we need something to standardize the OCT angio. So every machine had a different parameters and a different ways to calculate it. So this is OCTA is an open source, validated, standardized software toolbox that allow us to calculate the vessel density, the vessel length, average distribution of the vessel diameter, average and distribution of the vessel length, vessel tortuosity, and fractal dimension. So what are the future prospects with all the parameters we have? One is that these machines, with the help of the AI, can automatically identify these flow void area which Dr. Andrew talked about, and they can track in a distant area that the disease is getting reduced. So the machine can give you a red sign when the disease is further progressing. So that can be used. Apart from that, fractal dimension measurement along with the structural quantitative parameters can be used for progression analysis in ARMD. OCT angio, wide field OCT angio, with these parameters in place, can also identify the cases where we are going to have the way these cases are going to progress to, and the development of ischemic CRVO. Apart from that, progression analysis can also help us to tell, apart from OCT angio, can also help us to tell that these are the patients which will develop NVG in later course of life. Thank you.